the neuroscience of schizophrenia.
Conference record has joined the conference.
And I do want to mention the call is being recorded for those people who want to go onto the call who can't make this particular time. The way to access the calls are www.nami.org/askthedoctor. And you'll see many of the field's best thinkers, and you can listen to the call. In order to promote the quality of the call, I asked people to hit *6 to mute themselves. So this will help with barking dogs and other adventitious noises. When you want to make a comment or ask Dr. Goff a question after his introductory remarks, we ask you to hit #6 and then you can rejoin the call. Call goes for about an hour. It's a bit of a free-for-all when the Q&A happens. We don't have a way to organize it, but such is the delights of low technology. Just to give you a little bit of an idea about our guest expert today, Dr. Don Goff is the Marvin Stern Professor and Vice Chair for Research in the Department of Psychiatry at New York University's Medical School. He's also the Director of the Nathan Klein Institute for Psychiatric Research, which is a very prestigious position in the field. He also used to be the Director of the Schizophrenia Program at Mass General Hospital and was a Professor of Psychiatry at Harvard Medical School before moving down to New York. Are you getting an echo? Are you folks hearing an echo? Or is it just me?
Yes.
Quite a bit. Emily, are you on the call?
I am.
Would you do me a favor and see if you could help us with that by contacting our friends?
Sure.
Yeah.
The echo seems to have gone away.
It seems that Emily has almost magical powers, it seems.
Yeah.
So what I'm going to do is say thank you to Dr. Don Goff, who will be talking to us about Clozapine. If the audio is a problem,
hang up just a minute.
We'll try to sort the problem. *6 mutes you, which will help for the audio quality. And Dr. Goff, thank you so much for your time, and we appreciate everything you do.
Great. Thank you so much, Ken. I mean, it's a real pleasure. This is the second time I've done it, and I thoroughly enjoyed the last time we did this. And Clozapine is a wonderful subject to discuss. So I'm sure most, if not all of you, already know quite a bit. So what I'd like to do is save as much time for questions as possible, and just give a very quick overview, a little bit of the history, because Ken and I really lived through the early days of Clozapine and to the point where we are today. So I'll talk a little bit just about the history and how it's affected the field, and the high points in terms of what one needs to know about the advantages and disadvantages of Clozapine, some of the risks, and then we can talk about just the details about how a person can be, how their medication can be adjusted to try to avoid certain side effects with the medicine. So going back, I mean, surprisingly, Clozapine, the molecule was first synthesized way back in the late 1950s, and the very first antipsychotic, Thorazine or chlorpromazine, was introduced in 1954. So that's really sort of the beginning of the history of antipsychotics. And as you all know, the first, Thorazine or chlorpromazine, totally revolutionized the field, meaning many people who were otherwise going to spend long periods, if not most of their lives, in large state institutions, were allowed to through the use of chlorpromazine or Thorazine to be discharged, and that was a very important step towards development of community psychiatry and eventually the recovery movement. But after Thorazine, then there were a lot of antipsychotics that were developed, about a dozen up until haloperidol or Haldol, which was the last of that group. And I entered the field during the days of haloperidol or Haldol before Clozapine was approved in the U.S. And by then, the early excitement of antipsychotic medication had really dimmed, and it was really a very kind of demoralized field in terms of the treatment of psychosis or schizophrenia. There was no sense of really hope or of recovery. Our medications were causing a lot of really awful side effects in terms of movement disorders and making people stiff and Parkinsonian. And the drug companies had more or less given up on developing newer, better treatments because really no advances, significant advances had been accomplished since the first drug, Thorazine. And then seemingly out of the blue in 1988...
I'm getting a little background noise. Could everybody please hit *6 for us? That will just help you mute for background noise. And when you have a question for the Q&A section, you can hit #6 and Dr. Goff will take your questions. Thanks, everybody, for your patience.
Is that better? Sounds good. So in 1988, just seemingly out of the blue, John Kane and colleagues, having learned that this this molecule, clozapine or Clozaril, was in early trials, it seemed to be more effective, but had been put on the shelf because of this the side effect of agranulocytosis, a potentially lethal side effect. Decided that in the absence of any other more effective drugs, it really was worth giving it a second chance. So John Kane and his collaborators did this major classic study where they demonstrated that clozapine was in fact more effective than the other antipsychotics, in this case primarily Thorazine. And that was just a monumental study in 1988, and that study allowed clozapine or Clozaril to then become available, and in the early 1990s, there was kind of a second revolution of treatment of folks with psychotic illness that hadn't really responded well to the first group of medications. And so that's really where at least I entered the field, right around those days. And those were very exciting days. And that was, I think, a time when there was new hope, not only among family members and clinicians, but also the whole pharmaceutical industry was, for the first time, shown a sign that we might be able to do much better than our older medications. And so that actually prompted this whole second round of drug development, starting with drugs like Risperidol or Risperidone, and the more recent drugs now, in trying to follow this example of a more effective drug, which is Clozapine. And that even included some of the companies taking the Clozapine molecule and just changing it chemically a little bit. So both olanzapine or Zyprexa and quetiapine or Seroquel are chemical derivatives of Clozapine. So there was this effort to try to capture the greater effectiveness of Clozapine without the side effects. And as I'm sure most of you know, none of those attempts really have succeeded, meaning there have been some advantages with the newer drugs, but none of them have managed to equal Clozapine's greater efficacy. And it remains, shockingly, what are we, 30 years later, 20 years later, where we still don't really know why Clozapine is so much more effective than the other drugs. And so in terms of how is Clozapine more effective, and there's a little bit of debate about this, but I think most researchers, and I think almost all clinicians who use these drugs, are very clear that in many people, Clozapine is much more effective for the psychotic symptoms, so delusions and hallucinations. It can be remarkably more effective for aggression and hostility. And it's been demonstrated, and the FDA has approved it for reducing suicidality. And so those are, I think, major, well-documented advantages of Clozapine. There's a fairly good indication that many people find it easier to stop substance abuse, like smoking or alcohol, if they're on Clozapine compared to the older drugs. And in our clinic, I was most impressed that Clozapine seemed to prevent people from relapsing. And so when Clozapine was first introduced in roughly 1990, and we were converting people in our clinic, and we converted about 100 people, starting them on Clozapine. And in those days, knowing that it was so much trouble, meaning the once-a-week blood draws, and there were so many side effects, we really thought that we would give people an opportunity to try it, and that most would end up deciding they didn't want to continue on it. But we were amazed back then that almost every person who switched over to Clozapine chose to remain on it despite the side effects. And over time, we found that even some people whose say voices didn't seem to improve that much, or who still seemed to have delusions, nevertheless they seemed remarkably more stable. And many of these people would end up going back to the hospital once or twice or 3 times a year, and just after switching to clozapine, they seemed not to require hospitalization again. So there are, I think, other ways in which clozapine can be very helpful that we may not immediately recognize, but I think people taking it can often recognize that they feel better, and over time we often find that people don't relapse under stress and can more easily stay out of the hospital, which obviously is so important to avoid that disruption to people's lives. So there really is quite a long list of therapeutic benefits of clozapine. Now, I didn't mention cognition because, unfortunately, it doesn't really help people with attention or memory. And negative symptoms, meaning apathy and loss of emotional expressiveness, may sometimes improve with clozapine, particularly compared to the older drugs, but it's not nearly as dramatic an effect. So the dramatic effects really are with psychotic symptoms and aggression and suicidality and probably preventing relapse. Now, and also major benefit are the side effects that don't occur with clozapine, and particularly compared to the older medications, again, like haloperidol or Haldol or Prolixin. Clozapine doesn't cause the same movement disorders like tardive dyskinesia, the irreversible movements, often of lips or tongue or fingers. It doesn't cause what we call Parkinsonism, where people become sort of stiff and look, they have a tremor and they're very slowed down, and it can really disable people if they develop Parkinsonian side effects. And then akathisia, which is this restlessness in the legs that can be very uncomfortable. So clozapine doesn't cause those side effects, and that's probably one reason why many people really prefer switching to it. I should say that the newer medicines, introduced over the last 10 years, also tend to be better for those side effects. So that's all on the positive side with clozapine, and those are really very substantial benefits. And for some people, these benefits can really turn around their lives. To someone who's frequently ending up in the hospital and whose psychotic symptoms are really interfering with functioning, when if they successfully respond to clozapine, which is probably a third or half of people, that can really start them on the road to, say, going back to school or working or maintaining their lives outside the hospital long enough to really get on track. So what are the disadvantages? Unfortunately, the disadvantages are many with clozapine. There are what we call 4 black box warnings, meaning the Food and Drug Administration, when they approve a drug or subsequent to it being approved, they identify side effects of particular concern. So the major side effect, which has gotten the most attention, is agranulocytosis. And that is quite rare. It's less than 1% of people who take clozapine experience this side effect. And it basically is a loss of white blood cells. And so white blood cells are critical in terms of fighting infections. And if agranulocytosis were to occur and not be detected, a person would be at really great risk for developing serious infection, and could even die from it. So even though rare, that's serious enough side effects that has been the reason for the monitoring systems, and a person cannot take clozapine in the United States unless their clinicians are reporting their white blood cell counts on regular intervals. And with this in place, it actually reduces the risk dramatically. And so white blood cells tend to, for the most part, gradually drop with the frequent recording of white blood cells, meaning with blood tests. It can be identified early enough so that the medicine can be stopped or halted, and the white blood cells almost always come back in time to avoid serious side effects. So that's part. So even though because of the monitoring, it's not as dangerous as it might have been. So the risk of someone actually developing it and dying from it is really, really small. Nevertheless, the blood drawing does introduce a major inconvenience for people taking it. And in the beginning, they have to have blood tests once a week for 6 months, and then for the next 6 months, every 2 weeks, and then after that, once a month for the rest of the time that they're taking it. And that's because almost all cases of agranulocytosis have occurred within the first 6 months of people taking it. The other side effects, none are quite that serious except for what's called myocarditis. Myocarditis is even less rare than agranulocytosis, but it's the clozapine in about 1 out of 500 people or 1 out of 1,000 people can cause an inflammatory reaction in the heart muscle, which can really injure the heart. And so this is, again, very rare, but can be very serious. Some people can even die from this. More commonly, I shouldn't say commonly since it's very rare, but more typical of myocarditis is a person, it's almost like they've had a small heart attack, so they can suddenly find that it's difficult to, say, walk upstairs. They might have a little shortness of breath. They might feel a little dizzy. And this side effect is very rare, but also happens early in the course. So it's very important that doctors get an EKG before they start the medicine and just listen very carefully for these sorts of symptoms when people start clozapine. The other side effects are it can trigger seizures or epilepsy, particularly in people who are prone to it, and so that can be managed with anticonvulsants or by going very slowly up on the dose. And all antipsychotics seem to be linked with very, very rare instance of death, and it's not clear exactly the cause of it, but every antipsychotic has this warning, and clozapine may also, in rare cases, can cause respiratory or cardiac arrest. There have been quite a few studies of mortality in people with psychotic disorders, and even though there may be a slight increase in sort of sudden cardiac death, when they look at these studies, the actual death rate drops quite a bit when people take clozapine compared to if they don't. And it's thought because clozapine is so much more effective in terms of preventing suicide and violence, and it seems to be in this kind of trade-off. A person is much safer in terms of taking clozapine than not taking it. But there are these very, very rare, potentially serious side effects that need to be watched for very carefully. The other, and although it's not identified in the package warning, there is something called pulmonary embolus, which is also very rare, but a person can suddenly have difficulty breathing while taking it, and that's also an emergency that needs to be attended to. The more common side effects, so what I just described, very, very rare, only clinics that treat many, many hundreds of people are likely to ever see it, but the side effects that are just very common and troubling, but side effects that most people taking the medicine end up feeling are worth the trouble because of the benefit they experience are, first of all, weight gain. And for those of you who have family members or who are taking Zyprexa or olanzapine, clozapine is similar, possibly even worse in terms of causing weight gain, increasing appetite, probably slowing metabolism. We did a study years ago at the Mass General Hospital where over 10 years there was average weight gain of about 20 to 30 pounds over 10 years, and about a third of people on clozapine during that period had developed diabetes. Those rates are higher than most other clinics that have studied it since then, but nevertheless, it is quite possible to gain. Some people gain very little, some may gain 10, 20 pounds, but there are cases of people who gain, even more than 30 pounds, say 50 pounds. So that's quite variable. It's hard to predict, but something that really needs to be closely monitored, and everything possible in terms of management of diet and exercise is important. Weight gain, as you all know, can put a person at risk for diabetes clozapine can also raise lipids, cholesterol and triglycerides. So it does, in fact, over the long term, potentially increase a person's risk for heart disease. And that's a real concern. There are medicines now like metformin that can be used prophylactically to try to prevent some of these side effects from clozapine. But again, needs to be watched very carefully, and from the very beginning, people need to be helped to try to manage this weight gain because it's a real concern. The other very common side effect is sedation, and it tends to be much worse in the very beginning for people starting clozapine. It can make it hard to work or go to school, and so it often requires adjusting the dose. So a person takes most of it at bedtime, so the sedation is occurring while they're asleep, and various other things that can be done. And usually over time the sedation gets better, and for most people they can then go to school and work. But some people find they're sleeping more, say 12 hours on clozapine, and so we really have to work to help people with that. Some people find that they have more saliva production. They find themselves drooling, particularly during sleep, and that's something we need to, there are a number of remedies for that, but we need to watch carefully so that people don't, say, choke on their saliva while they're sleeping. So it's very important to always inquire about whether someone wakes up at night choking on their saliva, so we can either lower the dose or give them things to prevent that from happening, because that also could be serious. The other common side effect is constipation, and constipation can also become quite serious if it's not caught. So say, again, if you have a family member taking clozapine, we really need to keep track of all of these potential side effects to catch them early. Constipation can generally be prevented with diet or with various medications. If not caught and allowed to continue, people can run into very serious medical complications. So those are really the sort of the primary factors with clozapine. And basically, in summary, it's a lot more trouble for people in terms of blood tests. There are these side effects that weight gain can be very distressing in terms of self-image and long-term cardiac health. But on balance, clozapine can really be, for some people, transforming in terms of allowing them to overcome psychotic symptoms, to overcome the sort of continual disruption of relapse and hospitalization. And in my experience, when people are really debating, I often just say one really can't tell how this balance will turn out until one tries clozapine. And probably most people need to take it for, say, up to 6 months to really experience the full benefit of it, and then they are really in a position to decide whether the benefits outweigh the side effects. If someone's already doing well, then obviously we wouldn't want to subject them to these side effects, particularly the weight gain. So let me stop there, and I would love to take any questions, or Dr. Duckworth can correct any errors I made.
That's a great summary, Dr. Goff. So let's do our best to, collaborate to get the questions answered. So if you're going to ask a question, hit #6, unmute yourself, and ask a question for Dr. Goff on clozapine and all its manifestations, positive and the risks.
I have a question. Can you hear me?
Yeah, perfectly. Yes.
Hi, I'm a parent. We have a 16-year-old son who's been on clozapine for about a year and a half, and it's been a life changer for him. We have heard that perhaps at some point we should discontinue the clozapine for a period of time, and I was just wondering if you were familiar with that, and if so, what the reasoning is for that.
Yeah, the sort of no one has ever really studied that for sure, and all of this comes down to as in really all cases, it comes down to weighing the risks and benefits. If a person didn't really do well on other medicines but did very well on clozapine, it's unlikely that stopping the clozapine and going back to those other medications will be any different. That the unique response to clozapine tends to remain that way. if your son is having just intolerable side effects, or really if it's really sort of jeopardizing his health, then obviously one would want to think about it.
Right.
There's also something else that I usually don't mention because I'm not sure what to make of it, but I've seen it often enough. I'd be curious if Dr. Duckworth has seen this, of people who have had really good responses to clozapine and then stop it for various reasons, and then when they return to it, they never quite respond to it the way they did the first time. And I just one often hears sort of anecdotes of that. Many people stop it and then start it again, and they have this similar response. But I wish we had more information about that, because if that were true, that would, in terms of when you're weighing these potential benefits and risks, that would be something I would add to it. But I would have to say that I've seen that in a few cases, but it's really hard to know if that's a real risk.
But you're not.
Yeah, this is Ken. My answer to that would be, what would be the best reason to stop it, or to try a different medicine? What you typically find is people do have trouble with the side effects, and so you try to go with the lowest effective dose. Mm-hmm. But it's hard to know for sure. Whether stopping the compound, because usually people, who've gotten on clozapine have severe symptoms that haven't responded to less complicated and toxic compounds.
Right.
And so usually, you'd hope to, reduce the side effects as much as you can. But the truth is, I think you're out of a scientific realm. That is to say, it hasn't been researched, and you have to use really good judgment. What I would encourage you to do when I have my patients at the first episode of Psychosis Clinic at Mass Mental Health Center, when they want to go down on clozapine, we go very slowly, and we notice the symptoms carefully. We bring their loved ones in to be mindful, and we take blood levels. One of the advantages of the clozapine is you can get a sense of what the person's blood level is. So you have virtually no symptoms at a blood level of 300. I find that people in their younger 20s, having been on it for 4 or 5 years, say, "Doc, I feel great. I want to go off of this." So it's a different conversation as opposed to a doctor initiating. It says, "Doc, I feel great. I'm back at Bunker Hill Community College. I'm getting A's. I want to move ahead. I don't really need this stuff, do I?" So, in that case, it's a complicated conversation because it's hard to know with certainty. I tend to be conservative about making changes, but I also try to respect people's decision-making, and they have to live with these side effects.
Right.
So
I totally agree with slowly, gradually decreasing the dose in that case.
Okay. But you're not familiar with, because we have actually he's had very few side effects, but you're not familiar with any reason to discontinue because of some sort of concern about long-term use of the drug?
Well, in my view, I would just want to see if there are any warning signs of early diabetes or heart disease. In terms of looking at his blood tests, triglycerides and things like that. Because some of the side effects may be cumulative over many years, but if he's doing well, I would be very loath to stop it entirely. But as Dr. Duckworth said, trying to lower the dose. If he is developing some blood test changes that might be worrisome, then I think that would make sense.
Okay. Thank you very much.
Sure.
It's a good question.
Can you hear me? I have a question.
Go ahead.
Hello?
Go ahead.
Okay.
Yes.
Thank you. I have two questions. One, you mentioned stopping the medication if the white blood cell count goes down, and then the question would be, what do you do after that if clozapine is really the drug of choice? That works the best, And number two, mentioned stress and schizophrenia. How does stress affect schizophrenia? My son's 25 and working full time, and his delusions are strong right now while he's working during a stressful period at work.
Yeah, so two questions. First is about stopping it when the white blood count goes down. And there, when we check the white blood count, say weekly or whatever schedule your son's at, there are these different thresholds. And so if it's gone down below the first threshold, we then just check the blood count more frequently, and if it drops further, then we have to stop the clozapine and wait for it to go back up, which often just requires a few days. And then there's one threshold, which sort of defines agranulocytosis. So it's the cutoff that represents a potentially more dangerous drop in the white count. And unfortunately, if the white blood count drops below that threshold, then we really can't expose the person to clozapine again, and that can be heartbreaking when someone has done really well and their white blood count drops below that level, and then because of the risk of it happening again, if ever the person takes clozapine again, then we're left having to tell the person that we can't restart the medicine. I can go to your second question if that was clear
please.
enough.
Yeah, thank you.
And then the others is hello?
Oh, I have a question.
Okay, let's finish this one.
This was a two-parter, so just very. Although I don't know if we can answer this quickly, and I'm be interested in Dr. Duckworth's response. But it's the question about stress and relapse in someone who's prone to psychosis, and it's very complicated because stress can make things much worse. People can be very sensitive to stress, and people can become more psychotic. But then it sort of becomes, what's the nature of stress? Because, there was a time when psychiatrists would discourage people with schizophrenia from working, from going back to work or school because of concern about stress, and then discovered in many studies and experienced that people actually did much better when they were working or going to school. But so it probably, and I remember when 9/11 occurred, we were in the midst of a very large study at many different institutions, and people looked at what happened to patients during 9/11, and really there was no relapse related to that. That it's probably a different kind of stress that can trigger it, and it's probably interpersonal stress and difficulties with family members or other forms of stress that can really cause the problem. And so it's a matter of really understanding for the individual what their experience of stress is like. But I'd be curious if Dr. Duckworth has thoughts on that.
That's probably a very long discussion, probably more than we can answer on a clozapine call. What I'll try to do is I'll try to devote a call to stress management and psychosis in the future because it deserves that much time.
Yeah,
Thank you.
Okay, another question for Dr. Goff on clozapine, please.
Dr. Goff, I would love to come back to the question of weight gain because my son feels a lot of shame and he sometimes gets blamed for the weight gain. Mm-hmm. And I think it would help him a lot to understand what the biological mechanism is. What is it about clozapine and other antipsychotics that creates the weight gain? Do you follow my question?
Yeah, it's such a shame in terms of in this country it's stigmatizing to gain weight, and and particularly when people are first developing the illness, they're already suffering from so many aspects of stigma in terms of the dealing with the illness itself, and then to add weight gain is just really unfortunate. In terms of the why it happens, we don't fully understand, but at a more basic level, drugs like clozapine or olanzapine, Zyprexa, increased appetite, just generally increased appetite, and probably preferentially for carbohydrates. It also, in many people, it kind of eliminates the sense of being satisfied, the satiety response. So, although I find as increasing as I get old, I'm having the same problem. But so a person having a meal, will at some point feel like they're full and not be hungry anymore. But often on a drug like clozapine, that doesn't happen, and they can eat far more than they need at a single meal. And then in addition to that, it really slows down metabolism, partly because of sedation, and so people tend not to get much exercise, but also it's probably slowing down the way the body handles adipose tissue and calories. So there are probably many reasons why it's so difficult for many people to avoid weight gain or to lose the weight once they gain it. Having said that, I've seen quite a few people manage to lose the weight when they're in fairly intensive programs and really working at it. So it's not impossible. But it's very important that people not blame themselves, and that family members and ideally people in their immediate circle really understand that this is an effect of the drug and not the person's lack of discipline, say.
A basic strategy I encourage people to do is to get a nutritional consultation and to use the idea of having a plate. Because if clozapine deadens your ability to feel full, you have to rely on more external strategies. I'm going to have a plate of food, but if there's a bowl of mashed potatoes on the table, you're likely to keep eating. And so nutritionists can be good at these strategies that remind you of caloric limits. That's not the whole answer, but it is very important. Clozapine does change your sense of fullness. And I have also found that some of my patients don't really get good informed consent on that. They're surprised by that. Their appetite increases. So I think, Dr. Goff and I really feel that's very important to know. This is not your fault, but this is something to try to anticipate and plan for if at all humanly possible.
And I think along those lines, the environment is so important, and that ideally a person taking clozapine will not, will have appropriate portions served to them and not be at a table with a lot of food within reach, or not have a lot of fattening foods, snacks around them, or sweetened beverages.
Hi, I'm getting some background noise. If everybody could hit *6, please, I'd be grateful. Another question for Dr. Don Goff on clozapine.
I have a question, kind of a comment. Make that?
Yeah.
Hello?
Go ahead.
Okay. My son was on clozapine, and he had a seizure. And the doctor, the neurologist that came, said, I'm not sure what caused the seizure, but I can fix the weight gain. He was a 300-pounder. And he gave him a seizure medication called zonisamide, and he said it'll take a while. And over the course of a year, he lost 100 pounds, and he's kept that off. So I just wanted to share that and ask the doctors what they thought about that medication. It's zonisamide. The doctor, the neurologist, said that this medicine would retrain his brain and his stomach to communicate with each other, and it looks like, and that after he went off it, he maintained the weight loss. But then he went back on it for another reason. So just wanted to share that and see what you thought of it.
Yeah, no, I have not heard that before. In fact, I'm actually looking up zonisamide as we speak.
It was
Have you heard of that, Ken?
No, I have not heard of people using Zonogram for weight loss. One of the tricky things is, doctors do things off-label, but to my understanding, that compound is not FDA approved for that indication. So it may be that in his travels as a neurologist, he's observed that phenomena, which I also was aware of. But, we always want to be mindful that this would be a off-label, non-FDA approved indication.
So I'm just saying, so it is related to topiramate, which is sort of more commonly used for weight loss. So it's chemically similar to that. If it's like topiramate, we sometimes use that. It can sometimes affect memory and concentration, so one has to be careful. But I will look that up. I mean, that's an interesting thing.
Thank you.
For me to learn more about.
The NAMI membership has always got something. I learn something every time. So.
Actually, I should be quiet and just ask questions from now on.
Another question about clozapine. Go ahead.
I have a question.
Go ahead.
Does prolactin levels increase with clozapine, which is what happens with Risperdal and Invega and some other antipsychotics?
Yeah, that's a very important question. So risperidone and Invega or paliperidone are unique among the newer medicines in terms of raising prolactin. So the older medicines did, and then those two drugs do, but clozapine does not elevate prolactin at all. Most of the other newer ones do not elevate it, and some even lower it if they're added to the other drugs. And the issue about prolactin elevation is also, since clozapine doesn't elevate it, it's probably less germane. But I can say that if prolactin is elevated, it can cause some side effects, although, just the very presence of elevated prolactin is not worrisome. However, particularly in young women, if the prolactin level gets too high, they can lose their menstrual cycle. And then there's the concern that they may over time lose bone density because it's almost like entering menopause in terms of effects on bone. But that is in fact not a problem with clozapine.
Oh, that's good. Thank you.
Yeah.
There was a gentleman that had a question. Go ahead.
I have a question about my son.
Go ahead.
He has just begun Clozapine, and I'm curious about. He's in the hospital. I'm curious about what is a reasonable dose to begin him on, and what would be the highest dose where he would reach, I guess, therapeutic level, and how quickly might we see some changes in his behavior?
Yeah, something that I've not really emphasized, but I should, is that it's very variable in terms of side effects and the necessary dose between individuals. So some people say, in terms of what you're asking, some people when they start it have almost no side effects and can go up very rapidly. Other people, when they start, feel dizzy, and they can lower their blood pressure, or they're so sedated they don't tolerate it. And so for those people, they have to start at a much lower dose and go up very slowly. So I can't really help you in terms of predicting what to expect with your son. And, but I think once he has started on it, then his doctors will get a sense of to what degree these side effects are going to be slowing down the process for him. And the same is true in terms of what ultimately is the best dose for someone. Some people get by on relatively low doses, 100 or 200. Other people seem to require very high doses, 700, 800, up in that area. And as Dr. Duckworth said, blood levels can be a very good guideline. So these blood tests are not to monitor the white counts, which we talked about for safety, but these are blood tests that actually measure how much clozapine is in the blood, and there are cutoffs that can give a doctor a good idea of whether the person's in a range that should be therapeutic for them. But people metabolize or handle the drug quite differently, and so from the dose you can't really predict what the blood level will be.
I've also found that it's important to go slow for many people who are first starting the drug, and to stay with it for months and months, as Dr. Goff had said. So I had one patient on day 3 tell me their voices had stopped. That was the earliest response I've ever had. But I had a patient tell me after about 6 months, this is actually really helping me in a way it wasn't after 3 months. So the idea of starting low and staying with it. This is a unique medicine. There's nothing else like it. So to take this compound on is a commitment, and the idea is you do it as gently as you can in the goal of keeping the person on it, because it may very well, really transform their psychosis, obviously with many possible complications and risks. Another question for Dr. Goff on clozapine.
I have a question about the anti-seizure medication in conjunction with clozapine. I know you said clozapine can cause seizures and be handled with anti-seizure medication, but I seem to recall hearing that anti-seizure meds would interfere with the effectiveness of the clozapine. Is that true?
It doesn't seem to be the case, although there's sort of two aspects to this. Some anti-seizure medicines would actually lower the blood level of clozapine, so they would sort of speed up the body's clearance of clozapine. So there's some antipsychotics that we wouldn't add to clozapine for that reason. But the other anticonvulsants or anti-seizure medicines tend not to interact with clozapine and tend to be safe. And if someone already has epilepsy, we can still treat them with clozapine if we just go very slowly and make sure they have their anticonvulsant and work with their neurologist. Or if someone develops epilepsy while taking it, it's often possible to control it by adding an appropriate anticonvulsant.
Okay, I'm thinking of someone that has also bipolar or let's say schizoaffective, and are taking Depakote or the divalproic,
So Depakote can be combined with Clozapine.
Hang on, I'm getting a whole lot of background noise, folks. If you have to have a side conversation, please hit *6. It just makes it very difficult for people to hear the call. And thank you so much.
Yes, so both Depakote and lamotrigine are anticonvulsants that are used in bipolar disorder, and both are frequently combined with Clozapine. Depakote can cause weight gain, and so we just have to be very mindful of that. But that is commonly done and doesn't seem to undermine the effectiveness of Clozapine.
Thank you.
Our son has been taking Clozapine since 98 for 16 years. And my question is, can this blood test requirement be made a little bit more liberal rather than once in 4 weeks or once a month, but once in 2 months? I understand that is what is happening in Europe.
Yeah, a couple years ago I had heard that they were working on making it, as you said, more lenient after time. I've not heard anything more of that. The person at the FDA who was involved with that stepped down and has been replaced, and I don't know if that the push to have that done was carried on or not. I'll have to check on that. But currently, unfortunately, the once every 4 weeks continues for as long as the person's taking it, even though studies would suggest it's really so unlikely at that stage to occur that it may not be enforced.
Hello, Dr. Goff. Can I ask a question?
Sure.
Go ahead.
Sure.
Hi. I have a son who's 23 and who's been diagnosed with paranoid schizophrenia. My question is trying to help folks that are suffering with this illness when they have lack of insight and they're having psychotic and delusional thoughts, and we can't seem to get him help because he doesn't want medication and therapy, and he's not at the point where he would be a harm to himself or others. What can we do to try to help him?
Dr. Goff, I'm going to take that one real quick. The place that I refer people to is Dr. Javier Amador, Amador. He's on the Friday call from time to time and has written books and has, done a lot of talks in this area. And, it represents a tremendous challenge given that a whole subset of people are simply not aware that they have an illness process. Dr. Goff, you can take a quick answer if you want, but that, again, is a whole hour talk. It's a good question and an important one.
I have read his book. I have heard some of his programs. Still have not been able to help him or others with the LEAP method that he suggests, unfortunately.
I'm sorry to hear that.
I can't tell you how many parents I've sort of sat with and had this conversation because it's so common and so painful to watch someone who is suffering from the illness and not able to really evaluate the risks and benefits. And the only thing I can say is not to give up hope, because I've also seen in many cases eventually people based on experience or for other reasons, eventually being able to enter into that conversation and to give it a try. But it's a whole another complicated topic. That's for sure.
Okay, so there's nothing certain that professionals have come up with to try to help with that situation.
Well, the only thing I say is it's important for clinicians to engage people with the illness over what's important to them, so not to engage them around medicine or trying to cure their symptoms because people don't believe they have an illness and they don't want medicine, but to engage them about, the problems they're having trouble sleeping or they can't hold a job or they're feeling anxious, and then within that relationship, over time one can introduce the idea of medicine helping them to achieve their goals But obviously, if we are only asking people to take medicine, and if they don't believe they have a illness, then it's really very, very difficult to make any progress.
Great. Thank you for your help and for your work.
Oh, yeah, thank you.
Hello, I have a question.
May I ask
a
question?
Go ahead. I think we have a couple people. Let's just take them one at a time. Go ahead.
Okay. My brother is 50, and he has schizoaffective disorder since about the age of 25. We put him on Clozapine at the end of April, and sort of a two-parter. One is we're still struggling with a lot of sedation. He's gone from 300 milligrams to 275, but we're still struggling with a lot of sedation. I don't know if that's common or not. And secondly, it seems to us that his biggest challenge was disorganized thoughts and problems with cognition. I was sorry to hear, and I hope I didn't hear it correctly, that maybe Clozapine isn't going to help too much with that.
So, yeah, two good questions. The sedation, it's the usual approaches are one, as sort of we mentioned, sort of adjusting the dose, as low as possible, and giving as much of it, towards bedtime as possible to kind of eliminate the daytime drowsiness. Sometimes people try to add something, like a psychostimulant to help people feel more awake in the daytime. That can be very complicated and problematic. For some people that helps, but that's kind of a last effort that is sometimes used. But fortunately, a lot of people over time find the sedation gets better, and so it's a matter, I think, in the interim of just adjusting the dose and the scheduling the dose. The question about cognition, there's sort of two separate issues. So one is disorganized thought, which often is referred to as thought disorder, is viewed as a psychotic symptom. And so when people speak, they're illogical, or they have sort of odd ways of sort of organizing their speech or their thoughts. That often responds to Clozapine. So when I said doesn't help cognition, delusions are cognition and disorganized thoughts are cognition, but those tend to respond. The cognitive symptoms that tend not to respond are poor concentration if it's not being caused by psychotic symptoms. And so some people can't concentrate because they're hearing voices, or their mind is on their sort of paranoid fears. In that case, it may get better. But some people with schizophrenia just have trouble concentrating by itself, or some people have real problems with short-term memory, or some kind of sort of higher level thinking in terms of planning ahead. And those things tend not to, for the most part, to get much better with Clozapine. And that's a really intense area of research right now, trying to find treatments to help people with cognition. One approach obviously is cognitive remediation, which may be helpful for some of those things.
Cognitive remediation, just for a moment, is the idea of using the muscles of your brain, and that's something that I have. I do at the NAMI convention. I have experts in so-called cognitive enhancement therapy. Oh. And I've also had them on the Friday call. So that's the idea of using computer-based learning processes, often with other people, to improve some aspects of cognition. So I think that's an area that's very exciting, and it is something I'll be featuring on the Friday call. Another question?
Yes, Doctor, does Clozapine come in the injectable form? And also for people who lack insight, do you recommend starting them on injectable medications versus the oral medication?
Clozapine doesn't come in injectable form, and when we talk about injectable, by the way, so there's short-acting injectable, which is it's the same as giving a pill. It just is given by a shot, and then there's long-acting injectable, which is quite different. That's an injection that lasts for, say, 2 or 4 weeks, between injections. So I'm not sure which you're referring to. The long-acting injectables would seem to make sense for people who, are willing and agree that they benefit from the medicine, but for a variety of reasons aren't good at taking the medicine every day. And so they have lapses either because they get disorganized or, other things intervene. So the injections allow the doctor to know how much medicine they're actually getting, and it can get people through who might miss so many doses that they would be at a risk to relapse. But it's been hard recently in studies to show the benefit of long-acting injectables versus pills, and it may just be because people who volunteer for these studies are already good at taking their medicine, so it's harder to demonstrate its value.
The Europeans do use more injectable medicines than we do, and so I think it's also important to consider the possibility, that we may still have more to learn about the role of injectables in treatment.
The other thing about injectables, which I think is actually very important, is in many families or many situations, every taking of the pill is kind of a struggle, the person having to be reminded and being ambivalent and and if the person's only getting a shot, say, every 4 weeks, that completely removes that whole, process that can be cause a lot of friction and problems within, say, the family or the group home.
Hello?
Yeah, go ahead.
Hello?
Yeah.
Yes, I was going to respond to the woman. My son, too, is 25 and lacks insight and was diagnosed paranoid schizophrenia. The way we got him help partly is I got guardianship so that we could get him hospitalized so that he could be medicated, because to just have it go on and on, that he wasn't going to be able to help himself, so we had to act in that way. I just wanted to respond to the woman who has the same issues.
Thank you.
Yeah, and that's very important, that we didn't touch on something very important, which is there is this other element of whether someone's competent or not, and whether they're in danger if they don't take medicine, and then that sort of involves the approach that you've taken. Yeah, and it depends on the state laws.
It's just that when they say you have to be a harm, that is a very high standard. He was a danger in many ways, not deliberately, violent or anything, but just, the carelessness and the possible fires from burners being on, things like that. That isn't high enough for them to commit someone. So anyway, the guardianship was the route we went, and he needed help. He definitely needed help.
Mm-hmm. Well, that's a whole nother discussion that we'll do on the Friday call.
Yeah, very important.
I just wanted to give a response. Thank you.
Well, Dr. Goff, before we sign off, and thank you, do you have references, websites? How do people learn more about this important and complex compound? Like, do you have a best article, a favorite thing you've written, or?
Boy, yeah, there's so much written about it. I think in terms of just an overall article, I would have to think. Well, if someone want to search online, one of my colleagues, Oliver Freudenreich, has written a lot of very nice, very simple reviews. So his name is Freudenreich. Oliver Freudenreich. I would suggest maybe people just search his name for some of his recent guidelines about.
Excellent. Yeah, he's also on the Pulse. He's one of your mentees, if I'm not mistaken.
Right.
Yes. Well, I'd like to ask everyone to hit #6 so they can speak again, and just sing out a thank you to Dr. Don Goff, who gave us his time and expertise, and it was very wonderful to have you, Dr. Goff. We look forward to having you again in the future.
Thank you.
Thank you. Thank you so much.
Thank you all.
Thank you. Very important.
You feeling the love there, Don? Pretty good, huh? Thanks again.
Spell Freudenreich again.
Oh, Oliver, Oliver, Freudenreich. I pronounced it probably wrong. Freudenreich. And Dr. Freudenreich is at the Massachusetts General Hospital here in Boston.
Thank you.
And Dr. Goff was his mentor.